Good evening. Hope all of you all are doing well and deep into the studies for the Australian Dental Council exam for clearing your part 1 as it's already mid-July. August and September is your exam, right? So I won't waste much of your time. I could not shoot a video this last week much because my in-laws were over and it was a full house. Me being very busy with many things, and like today they have just left, and so I got some time finally and I can shoot the video. Very good question today. What am I solving right now? For all the previous candidates, this is the practice questions released by the ADC itself, and for all the new candidates, this is exactly how your exam paper would be like, with a scenario and 5 sub questions to it, to which you have to answer the answers. Now, today what I'll be doing is I'll be solving one scenario and I'll be showing you my book, this Ultimate ADC Companion book with similar questions, because after all I said they kind of take questions of the same concept. Like for example, this question is regards to oral surgery cyst. But then cyst also comes in pathology, it also comes in oral medicine, it definitely comes in oral surgery, and it comes in radiology. Okay, so all these 4 specialties of dentistry also we deal with cyst. One with diagnosis, one with treatment, one with maintenance of it, one with identification of it. So I will take the questions from these 4 specialties of dentistry and club together them to make a scenario. So if you are strong in your basic concepts from these 4 specialties with regards to cyst, then you can answer any question with regards to cyst. Understood? So they make a scenario so that it actually seems as if you are sitting in a clinic and a patient has come to you. So you are the dentist, so you should have the comprehensive knowledge of oral medicine, of surgery, of pathology, of treatment planning. It's another concept that you have to refer these kind of patients if there are huge cysts, but at least you are the first person of contact with the patient. So you'll be explaining the various treatments and you will be the first person to diagnose that lesion, right? Probable diagnosis, differential diagnosis. I'm not saying an absolute diagnosis because you haven't done the biopsy of it. So where do you get these sub-questions from? You get it from the individual specialties. And that is what I'll explain you what my Ultimate ADC Companion book is all about. It is about the individual subjects encompassing all the exam related sub-questions. And then you can pick 4-5 questions from each specialty and form a scenario which ADC has done. So my book is basically the question bank to the scenarios which are asked in ADC. Understood? So we'll go through that later. Let's first just solve the question. Very beautiful question, and you will encounter such a patient at least once or twice a year minimum. Even though it's very unfortunate for you as the first person to break the news to the patient what he has, you have to handle such cases with a lot of empathy, compassion, because the patient initially would be scared on just seeing the radiograph and you explaining as to what it is, because the treatments are often extensive, surgical, invasive, and not always a success is obtained. So of course you won't be the person who will be doing the procedure unless you happen to be the oral maxillofacial surgeon, but definitely to prepare the patient you play a very important role, even though you're not the one who's doing the treatment, right? Because you are the first person who's going to break this news to the patient. So anyways, let's just go ahead and start solving this question. Brian is a 30-year-old electrician who rarely visits the dentist. Rarely, okay? He has been aware of slight discomfort in the right mandibular area for a couple of years, so it's a chronic long-standing lesion. And he is being aware of that something is going on, but he doesn't know exactly what that is. Recently, he noticed that the discomfort had become a continual dull ache and he seeks your advice. So he had discomfort, he was aware of it. But what he did not anticipate was that it's going to become continuous, and when it did become continuous, he seeks your help to address the situation so that it's not a pain anymore. So basically, he's come with a chief complaint of pain on the right side, which has a history of discomfort for many years. Now, whenever such a patient comes to you with a long-standing chronic lesion, something definitely is going wrong. You know that, right? So now you have to diagnose it. Now, his medical history reveals that he takes insulin for type 1 diabetes, but which appears to be well controlled. So he's kind of a healthy patient with just a controlled diabetes, so it's okay. Otherwise, his medical history is unremarkable. You take a panoramic radiograph, OPG, see. The first line of treatment is always OPG. Advanced diagnostics is CBCT. The first line always stays as OPG. The first line is never CBCT, okay? You take a panoramic radiograph which shows a significant radiolucency in the right hand side ramus. The question itself says focus on the right hand side of the ramus. So you don't have to just look at the OPG and wonder what is going wrong. The question itself gives you where to look at in the picture. So this is the picture, and you see there is a significant radiolucency. You see where my arrow is going? Huge radiolucency in the ramus. You can compare this ramus to this ramus on the other side, and you see like practically the entire bone is being eaten up. It's just a outline of the mandible that is left. And then there is a tooth which is stuck inside. There is a missing tooth in the mouth clinically, but there is a tooth which is stuck inside the lesion. The first thing that will pop in your head that it is either a dentigerous cyst or a odontogenic keratocyst, because in dentigerous cyst you do have a tooth and the lesion is attached to the neck of the tooth. But usually you also have the root of the tooth in dentigerous cyst, and you will clearly see the lesion starting from the cervical region, that is the CJ junction of the tooth, but you would still see a root. Odontogenic keratocyst mostly does not have the root of the tooth. You either don't have a tooth at all and you just have a big lesion, or you have a tooth and a lesion but only the crown portion of the tooth and the root is usually missing. So given the size of the cyst, it looks like a very aggressive cyst. Dentigerous cysts also grow, but they usually don't like eat away the entire ramus, okay? Odontogenic keratocysts are known to be very aggressive, and they usually don't let the root formation happen and they just develop before that. So looking at the adjacent teeth also, you can see there is some resorption that has happened. It most likely looks like an OKC, that's odontogenic keratocyst. So that is your probable diagnosis. It's not like a final diagnosis, because the final diagnosis can only come after the biopsy result. So you should, the first line of the treatment I feel is that you will explain the patient very empathetically, and then you'll refer to the oral medicine and oral surgery people. Oral medicine people might take a biopsy of the lesion and then diagnose it as whatever type of lesion, and then refer to the oral surgery person who will do the treatment of it, because definitely a treatment is needed. If you keep the lesion as it is, it's going to fracture the bone. So anyways, this is what you see, and the first instance that you see, these are the impressions what I just described to you, correct? Now you will only know all this if you have read about OKC lesion and dentigerous lesions, correct? So if you haven't, I would say pause this video, open your oral pathology book or go on Google and read in details about the characteristics of these two lesions, when they are formed, which age group they are common, what is the treatment that is for it, right? So once you have strengthened your concepts on dentigerous cyst and OKC, then you start solving this question. Don't just jump, because this is not a question where you can mug up any answer. If you know the concept, you will know the answer. Now, what complication has affected the adjacent teeth as a result of the presence of the radiolucent mandibular lesion? Adjacent teeth, that's teeth number 4-7. You can see there is a root resorption here. The root is not as long as it should have been. So what does that mean? There has been a resorption. External resorption of tooth 4-7. Tooth decay on the distal surface of the tooth 4-7. I cannot see a decay. Deep pocket. I still cannot see a pocket. There is a bone and there is a gum line here. So I don't see a pocket. Displacement of tooth 4-7. I don't think so. There is a resorption. If it was displayed, it would have looked very weird. It pretty much looks in its own line in a proper occlusion. It's not displaced. So the right answer is external resorption of tooth 4-7. Dentigerous cyst often causes displacement unless it becomes a very huge cyst. OKC usually causes resorption of the adjacent teeth. It's more aggressive cyst than dentigerous cyst. That is also one of the markers. Now, what is the most likely diagnosis? Most likely. It means all the given diagnoses are correct. You have to choose the most likely diagnosis. For Bryan's presenting symptoms, metastatic tumor. What do you mean by metastatic tumor? Metastatic tumor means the actual primary site of tumor is somewhere else. Like it can be lungs, breast, stomach. And then the tumor cells have migrated from that place and again started a tumor on a different site. That different site is the metastatic site. There is no medical history, there is no mention of any other discomfort or cancerous type of lesion in Bryan's body in this scenario. So we will not jump to think that this is due to a cancer present somewhere else, correct? So metastatic tumor can be a diagnosis, but the symptoms and the scenario given to us does not point to it. Keratocystic odontogenic tumor, that is the OKC that I was talking to you about. Radicular cyst. A radicular cyst usually happens in a non-vital tooth, and the tooth is pretty much present in the mouth, and the cyst is developing periapically to it. This is not how that cyst looks like. Well, if they would have asked something about this area, you see this area on the arrow? Then probably I would have said this is a radicular cyst, but it's not. Then you have hemangioma. Hemangioma is a blood-filled cyst. Looking at the symptoms and the presentation of it, it does not look like an hemangioma at all. So the answer is keratocystic odontogenic tumor. Which additional image would provide the most optimal information to assist in diagnosis of Bryan's condition? Additional image. See, it's not the initial image, it's the additional image. Many times, many of the candidates keep asking me, Doctor, if the option is given, what is the initial diagnostic imaging technique that you would do? And the options are OPG, CBCT. They just choose CBCT. I get it, CBCT is more specific, more advanced, but it's not the initial step. Not every clinic may have CBCT, and sometimes CBCT is done only for a specific area. But the initial diagnostic tool is the full scanning of the mouth, which is your orthopantomograph, that's OPG, correct? Additional image is CBCT. Here the options are CBCT, lateral oblique radiograph, periapical radiograph, magnetic resonance imaging, that's MRI. MRI is for soft tissue lesions. Here the lesion is in the bone. I would need a CBCT, hence the answer. Lateral oblique is not of such relevance to us if the option of CBCT is given. Periapical radiograph definitely is not going to capture this area. So that is not our scope out here at all. You inform Bryan that any increase in the size of the lesion could have serious consequences. It can fracture. What is the most conservative management to recommend for Bryan? Most conservative management. Continued observation is definitely not the answer here. The more you wait, it's just going to lead to fracture of the bone. You saw the lesion, like there's barely anything left in the bone. Cryosurgical procedure. It's basically putting a lot of cold with a probe. You kind of freeze the lesion, but and you excise it, but that is not suitable for this kind of a thing. Enucleation and extraction of tooth fourate. Yes, these lesions are very aggressive, so the best thing is to kind of remove the entire cyst along with the causing tooth. Mandibular osteotomy. Osteotomy is you opening the mandible and doing what? What will you do? That they have not mentioned. So mandibular osteotomy is not the answer. It is enucleation and extraction of tooth fourate. On Bryan's panoramic radiograph, you notice another mandibular radiolucency around the roots of 3/8. This, you can see this. What would be the most appropriate initial course of action be in order to address this? You will perform a pulp sensibility test. You understand? There is a cyst. Now, it can be Staphnase cyst. Staphnase cyst is just a depression in the bone, and sometimes it looks like a cyst. If you think it's a radicular cyst, then the tooth will be non-vital. Doing a pulp sensibility test will tell you that the tooth is vital. If it is vital, then this is either a Staphnase bone cyst or something else is developing which is not related to the tooth. It's related to just the bone and the structures of it, not related to the tooth. That is why you're doing pulp sensibility test. You understand? So this is how you solve the question. You can see the answer key and match my answers to it, and you will understand how we reach that answers. Now I will quickly show you my book before I sign off. Now this is my book, and I'm showing you the various questions on the cyst that I have put. You can pause this video, you can go through this. These are the sub questions. Now imagine I take 5-10 sub questions from different part of the dental specialties from all these subjects which are mentioned by ADC. You see the index, these are all the dental subjects. Now I take 5 questions from different topics mentioned here, and I club into a scenario. That is what the ADC question is basically about. And how do you strengthen these subjects? By solving these sub questions, basically the MCQs. This is my ultimate ADC companion book, encompassing all these subjects from the authors mentioned by the ADC from their resource. Basically, I've just served you the question bank on your platter. All you have to do is just solve and practice. So if you want this book, just email me on adcwrittenmocktest@gmail.com, and I'll be happy to share the sample copy of it. And if you like it, you can just buy it from me. So I hope you understood the question. I hope you understood how to solve the ADC questions. So happy studying, and always happy to read your comments. Bye-bye.